you can see in the image in 2017, California cattle production sales were $1 million or even billion-dollar industry. And because there's that high demand in this industry, California has been one of the top states with livestock operations. This causes some concerns to the nearby communities living in the said areas. So the most common health issues related to CAFO, as many researchers have shown, is respiratory diseases, but very little on adverse pregnancy outcome. And my research focused on preterm birth. So as you know, the current population have been showing concerns about environmental issues and have become more vocal about it. And due to that attention, the EPA, Environmental Protection Agency, have decided to reassess the CAFO regulation. CAFO has affected the environment, which in turn affects human health overall. So we heard of manure runoff to our groundwater supplies, which led to the Clean Water Act. And there are certain permits requirements from the National Pollutant Discharge Elimination System as well. But these regulations have been lacking and we could say have not been implemented well. So the most recent plan to reassess CAFO regulations, the Effluent Guidelines Program Plan 15, that just recently, launched last year, will focus on collecting further information to revise the effluent limitation guidelines for CAFO. So now that we know a little bit about CAFO, we should be aware, and why we should be aware of the issue. I will share some of the what I have done within my research. I did a retrospective cohort study and sampled California mothers from the 2004 National Birth File to identify mothers that develop preterm birth using 2007 CAFO dataset from the National Agriculture Statistics Services Census of Agriculture by the USDA. We identified the cattle head count per square mile. So what is preterm birth? Mothers go into premature birth labor, usually less than 37 weeks. And if these newborn are born early, developmental stages have not been fully completed yet. And there are instances where it could lead to infant deaths or even complications if they survive. So some of the issues that are stated in the slide are breathing problems, feeding difficulties, and so on. So here is a table on the demographic data of the sampled California mothers with a mean age of 28, mostly white, and at least 4 years of formal education in high school. And here is the top 10 CAFO density by county. So in California alone, we have about 50 counties. And out of the about 58 counties, we identified the top 10 with the highest number of cattle operations within the state. We found out in the 2007 dataset that top 10 counties are from the San Joaquin Valley area, which makes sense because that's where most of our agriculture industries are located, and Stanislaus being number 1 with 901 cattle operation for that specific year. Moving on to the data analysis part, we did a binomial logistic regression on the data we extracted from the National Birth File and CAFO dataset. Because CAFO density is not yet well defined, we did a cutoff and got the quartile percentile range and used less than 25th percentile as our reference group. Using the data we got from the preterm birth variable, we did an odds ratio and found out that the 25th to 50 and 50 to 75th percentile have an increased risk of preterm birth with 1.14 odds ratio compared to the reference group. The same goes for the above 75th percentile, where we also see an increased risk in preterm birth with an odds ratio of 1.06. With the analysis, we adjusted for mothers for age, race, and education, and the preliminary results are all statistically significant so far. So like any research study, we have strengths and limitation. And in my case, it both stem from our data set. So our strength, we utilize a large and widely available data. And we have collaborators that all did the calculations for the density information from our CAPO data set. And the limitations, we are restricted to using the data from 2004 National Birth File because of the county level information that from the CAFO data set that may not be presenting the current conditions of CAFO. And we also looked at the cattle only and not including the poultry operation as well and other factors affecting mothers' pregnancy outcomes. And in conclusion, based on the preliminary result, there's a risk of preterm births in California mothers living in the higher percentile of CAFO density when compared to the 25th percentile. And I would like to acknowledge just my faculty mentors, collaborators, and research programs that work on the research project with me. So thank you. If there's any question, I'm open to that as well.
Thank you so much, Pauline. Your research findings are very insightful.
Go ahead.
I'm sorry. Does anyone have questions? Hannah asked, are the health risks for CAFOs for poultry different from cattle? How do you think your research would be similar or different?
I think like, cause from what I can remember from the top of my head, in terms of the poultry industry, they have more than the cattle operations. So I would say that there could be a lot more similarities into it, but at the same time, because cattle is they have some exposures that are not available to poultry, like the greenhouse gases, because as we know, the cattle like cattle itself, they have exposure to greenhouse gases, but the poultry not necessarily. So there might be a slight difference, but I would think that there could there will be still risks that may or may be different in that sense. I don't know if I answered that question, but yeah.
Awesome answer. Do we have any other questions before we go ahead and move on to our next student? No? Okay. Dr. Preston, you can go ahead and have the honors of introducing Yazmin Acosta.
Thank you so much. Yazmin Acosta is a master's student in the Department of Public Health, specializing in environmental and occupational health and safety. She's a member of the CSUF student section of Orange County's American Society of Safety Professionals. Yazmin obtained her bachelor's degree in environmental studies and sociology from the University of California at Santa Barbara. Yazmin currently works at the South Coast Air Quality Management District, where she is dedicated to fostering a safe and healthy workplace for all employees. I also want to acknowledge that Yazmin was one of my students at 524 and also in last year's health policy conference. Yazmin, take it away.
Thank you so much, Dr. JP. So hello, everyone. Happy Friday. My name is Yazmin Acosta, and alongside my advisor, Dr. Mahmoudou, we examined the racial ethnic disparities in environmental respiratory allergies among cancer patients. So a little bit about environmental respiratory allergies. This is a chronic condition, also known as allergic rhinitis, hay fever, or seasonal or year-round allergies. This tends to occur when the body's immune system negatively reacts to certain substances, such as dust mites, pollen, pet dander, or mold. Some other common environmental allergens include air pollutants, such as vehicle emissions, industrial pollution, and particulate matter. Common symptoms include nasal congestion, sneezing, postnasal drip, non-productive cough, eustachian tube dysfunction, and chronic sinusitis. Some of us may be experiencing that right now during the spring season. So previous research has shown that environmental respiratory allergy significantly impacts the quality of life and morbidity in underserved populations. Environmental respiratory allergies can become a burden to deal with. This is especially true when individuals are already dealing with other diseases such as cancer. So cancer patients are already experiencing physical, emotional, and psychological challenges due to their diagnosis. Therefore, suffering from environmental respiratory allergies would create an additional burden that can decline patient care and their quality of life. So according to 2021 Centers for Disease Control and Prevention data, approximately 1/4 of US adults were diagnosed with environmental respiratory allergies. And in 2022, the CDC reported that 4.1 million doctor visits had a primary diagnosis of environmental respiratory allergies. So a lot of the time, some of us may confuse maybe having the flu or maybe even having COVID with environmental respiratory allergies just due to the similar symptomology. So our study examined the prevalence and association of race, ethnicity with environmental respiratory allergies among individuals diagnosed with cancer. We hypothesized that race, ethnic minority cancer patients are more likely to be diagnosed with environmental respiratory allergies than non-Hispanic white cancer patients. So for a research study, we analyzed 2021 data from the National Health Interview Survey. This is a cross-sectional household survey that is conducted every year in partnership with the CDC. Our plan was to analyze data for multiple years. However, environmental respiratory allergy data was unfortunately only collected in 2021, which is one of our limitations. The data we analyzed included sociodemographic and socioeconomic information of United States adults ages 18 and over. Individuals who were missing responses were excluded from our study, as well as individuals who indicated error in response or had multiple responses. So this led us to a total sample of 1,879 participants, all who indicated they had been diagnosed with cancer. We also ensured that all of our data samples were weighted to accurately reflect the larger US population. So our dependent variable was environmental respiratory allergies, and the question participants answered on the survey was, have you ever been told by a doctor or health professional that you have environmental respiratory allergies? The measure was yes or no. And once again, our total sample size was a total of 1,879 individuals, all who indicated they had been diagnosed with cancer. For our sociodemographic factors, we included age, sex, race, ethnicity, marital status, and region. And for our socioeconomic factors, we had education and health insurance coverage. So for our statistical analysis, we performed a total of 3 different tests utilizing SPSS software. The first one was a bivariate chi-square test to determine the differences in cancer patients with or without environmental respiratory allergies. We also conducted an adjusted logistic regression analysis, and this was used to examine the likelihood and odds of environmental respiratory allergies. And lastly, we performed an absolute difference and relative odds ratio, which was used to estimate the relative risk of environmental respiratory allergies. So here in this first chart, we can observe that out of our total sample of 1,879 cancer patients, a total of 1,043 of them indicated they had been diagnosed with environmental respiratory allergies. So this amounts to 55.5% of our total sample size. In this table right here, we observe the weighted descriptive statistics of environmental respiratory allergies and race ethnicity. If we focus on those who responded yes to experiencing environmental respiratory allergies, we can see that minorities have a higher prevalence rate compared to our non-Hispanic white cancer patients. So here we can see our non-Hispanic others multi-ratio had an 83.1%, non-Hispanic Asian 68.2%, Hispanic 62.7%, non-Hispanic Black or African American 65.2%, compared to our non-Hispanic white with 54.7%. Okay. So here, this table demonstrates the likelihood of race and ethnicity and its association with environmental respiratory allergies after adjusting for sociodemographic factors such as age, sex, marital status, and region. Here, we can see that our non-Hispanic others multiracial cancer patients are 3.44 times more likely to be diagnosed with environmental respiratory allergies than our non-Hispanic white cancer patients. This table here demonstrates the likelihood of race ethnicity's association with environmental respiratory allergies, but here we adjusted for our socioeconomic factors, and these were education and health insurance coverage. So here we have two statistically significant results. Once again, our non-Hispanic others multiracial cancer patients were 4.17 times more likely to be diagnosed with environmental respiratory allergies compared to our non-Hispanic white cancer patients. We also found that our non-Hispanic Black or African-American cancer patients were 58% more likely to be diagnosed with environmental respiratory allergies compared to our non-Hispanic white cancer patients. So here, this is our fully adjusted model. We once again see that our non-Hispanic others multiracial cancer patients were 3.50 times more likely to be diagnosed with environmental respiratory allergies compared to our non-Hispanic white cancer patients. And here we adjusted for all of our factors, so age, sex, marital status, region, education, and health insurance coverage. So we also wanted to see what the relative risk of environmental respiratory allergies among cancer patients would be between other race, ethnicities, and non-Hispanic whites. So what we did here is we created two categories. In one category, we had our non-Hispanic white cancer patients. And in our second category, we had non-Hispanic Black, African-American, Hispanic, non-Hispanic Asian, and non-Hispanic others multiracial. Here we can see that our relative risk demonstrates that our racial minority cancer patients were 22% more likely at risk of being diagnosed with environmental respiratory allergies compared to their non-Hispanic white counterparts. So summary of our research findings, bivariate analysis demonstrates a significant difference in cancer patients diagnosed with environmental respiratory allergies based on race ethnicity. The prevalence rate of being diagnosed with environmental respiratory allergies was 55.5% among our cancer patients. Non-Hispanic other multiracial had the highest prevalence of being diagnosed with environmental respiratory allergies with 83.1% compared to our non-Hispanic white cancer patients with 54.7%. Our non-Hispanic other multiracial cancer patients had significantly higher odds of environmental respiratory allergies compared to non-Hispanic whites in all of our adjusted models, such as sociodemographic, socioeconomic, and fully adjusted. Non-Hispanic Blacks, African Americans were more likely to have environmental respiratory allergies compared to non-Hispanic whites, and this was 58% more after adjusting for education and health insurance coverage. And racial minority cancer patients combined were 1.22 times more likely at risk of being diagnosed with environmental respiratory allergies compared to their non-Hispanic white counterparts. So this leads us to our limitations. So our study consisted of analyzing data from a cross-sectional survey, which can only support association. As previously mentioned, the National Health Interview Survey only provided environmental respiratory allergy data in 2021. So we would hope that they start collecting that once again. Therefore, further research should be conducted to investigate whether there is a direct causal relationship between race ethnicity and environmental respiratory allergies. So our findings demonstrate that racial ethnic disparities exist in environmental respiratory allergy diagnosis among cancer patients. Our study shows the importance of addressing racial ethnic disparities among cancer patients with environmental respiratory allergies. And this should be done in order to improve patient outcomes and quality of life. And in my personal opinion, this can be accomplished through a couple of ways. Oh, sorry about that. One would be by increasing access to healthcare services for minorities through preventative care, diagnosis, and environmental respiratory allergy treatment. We can also work towards educating our minorities on ways to prevent or reduce exposure to allergens by providing them with health education awareness and presenting this in a culturally competent way to reach diverse populations, as we learned in Dr. JP's class. Working to implement environmental interventions, such as addressing air pollution through policy and program implementation. And that's actually done at my current employer, South Coast Air Quality Management District. And last but not least, by continuing to conduct research and collecting data to better understand the underlying causes of environmental respiratory allergies disparities among our minority cancer patients. These are my references. Thank you very much for your time. Any questions?
Thank you so much, Yazmin. Your research was very informative, and I really like that the way that you shared with us. Does anyone want to have any questions for us? I wanted to ask, what future research directions do you think you could further enhance our understanding of ERA?
Yeah, so I'm not sure if you were able to see, and I'll pull it up really quick. Our total sample size here, right, was primarily our non-Hispanic white cancer patients. We definitely need to continue to reach out to our minority cancer patients and make sure that they're answering these very important surveys, right, national surveys. By collecting more data from our minorities, we will be able to reach them and hear their opinions, hear their concerns. That way we can address those. So I definitely think that, first of all, CDC needs to continue asking this question of environmental respiratory allergies. Like I said, they only had that question in the year of 2021. This was also during COVID, right? So maybe responses were very limited. So definitely going back and putting that question in that survey, the National Health Interview Survey. And once again, by reaching our minority populations, underserved populations, and trying to address their concerns.
100% agree with you. Thank you for that. We have another question from Hannah. She said, what do you think are the reasons for these health disparities that you found in this research? What are some ways do you think we can provide culturally competent resources?
Yeah, so unfortunately, a lot of our minority populations do live in urban areas, maybe from low socioeconomic status, may be working in places that expose them to more allergens, right? So this may cause more exposure to environmental respiratory allergies. Also, the lack of healthcare access. A lot of our minorities may not have time to go to the doctor, may not sometimes be untrust our doctors, right? They may not want to go to the doctor because I'm fine. I don't need to be diagnosed with anything, right? I may not have time because I have to go to work. I need to provide for my family. So all of these factors take into place, and maybe these minorities are underdiagnosed, or if they're not diagnosed in the first place, they may continue to suffer with these symptoms, right, which can be a burden to their quality of life. And Hannah, what was the second part of the question?
She said, what are some ways do you think we can provide culturally competent resources?
Okay. Yeah, so by reaching out to our minority groups, making sure that we do this in a culturally competent way. Some individuals may not speak English, right? So reaching out to them with individuals who speak their language, education, having community awareness programs, right? And making sure that we implement these in our underserved communities.
Again, thank you. Up next, we have Jared Ortiz. Dr. Preston is going to go ahead and do an introduction, but just a side note, we have until about 12:55.
Oh no, you have till 1:05.
Yeah, we have more time. Okay, so Jared, you'll have your full 10 minutes to ask questions, okay? Jared Ortiz Luis is a third-year public health major pursuing a concentration in global health. He got involved in epidemiologic research during the summer of his second year at CSUF when he completed the Allied Health Academy's Summer Research Experience Program and was matched into Dr. Bo Park's Perinatal Environmental Exposures Awareness, or PEAS, study lab. His research interests include environmental teratogen. Why'd you guys do this to me? Teratogens, which he will tell you how to pronounce, inhalation toxicology, and exposure science. Jared is also currently a student in my 411 course. Jared, take it away.
Hello, so let me just share my screen.
You can tell us how to pronounce that word I butchered.
No, it's okay. It's teratogens. But you're close. Yeah, you're close, Dr. JP. Let me put this. Okay. So good afternoon, everyone. I'm Jared Ortiz Luis, and today I'll be discussing the association between living near wildfire before and during pregnancy and the congenital heart disease risk in offspring. But before we get into the presentation, I'd like to acknowledge that this project was completed in the Perinatal Environmental Exposure Awareness Study, which is in an undergraduate and graduate research lab in the Department of Public Health. It is led by the marvelous Dr. Bo-Young Park, who is with us today. Below are some photos of both undergrad and grad students who've worked in the lab. One activity that the lab offers is epidemiologic research. We conduct many studies investigating environmental teratogens, exposures, and their impacts on maternal health and fetal development. So if you're interested in perinatal health, epidemiology, or environmental health, I'm sure there's a project in the lab that you'd be interested in joining. Another activity involves student presentations. Once you join the lab and begin work on a project, you'll have many opportunities to present at student conferences and get more experience presenting your work, which is wonderful preparation for those interested in graduate school. Lastly, the lab also offers both summer and winter workshops, which often focus on skill development, like practice using R and running statistical analyses. Additionally, while I didn't list it on the slide, the lab is a fantastic place to learn and grow. I can proudly say that since joining the lab, I've learned so many valuable concepts and skills in perinatal epidemiology and environmental health. And through joining, I feel like I have a greater understanding of the numerous contemporary issues facing both environmental health and women's health. So I highly encourage you to reach out to me or to contact Dr. Park if you find yourself interested in joining at the end of the presentation. And this next slide is just the photo that you're greeted with when you go on the lab website. I've attached the link below if you're curious or would like to further explore Dr. Park's background and the research we conduct in the lab. So before we begin, I'd like to ask, does anyone know how many wildfires we had in California last year in 2023? You can type it in the chat. I'll give you a couple of seconds to sort of think about it. You can take a wild guess. If your guess was over 7,000, you would be correct. We had approximately 7,127. Now, does anyone know what the leading cause of mortality is in the United States? Once again, you can feel free to type in the chat. If you said cardiovascular disease, you are absolutely correct. So as climate change continues to worsen our seasonal wildfires here in California, it has become increasingly important to understand the teratogenic effects of wildfire exposures. And as one of the more common birth defects, congenital heart disease, or CHD, affects approximately 1% of live births. So this study in particular will focus on the two primary types of CHD risk, which include atrial septal defect and ventricular septal defect following exposures to wildfires throughout pregnancy. The septum plays a critical role in the heart's anatomy because it functions as a wall that separates the heart's right and left sides. And so an atrial septal defect occurs when there's a hole in the heart's upper chambers, otherwise known as the atria, which results in communication disruption between both chambers. On the other hand, a ventricular septal defect occurs when there's a hole in the heart's lower chambers, otherwise known as the ventricles, which results once again in the disruption of ventricular communication. So we used a retrospective cohort study design and used data obtained from the California Office of Statewide Health Planning and Development Linked to Birth File and the California Department of Forestry and Fire Protection, otherwise known as CAL FIRE. And we used data from 2007 and 2010. And we used this time period because it had the most wildfire events with available linked birth file data, approximately 1,205 wildfires. And any pregnancies burdened by ASDs and VSDs were identified using the ICD-9. Pregnancies were considered exposed to wildfires if the mother's primary residence zip code was within 15 miles of the closest edge of a wildfire. So to sort of summarize our key findings, pregnancies exposed to wildfire were associated with a higher risk of ASD in the first, second, and third trimesters. And when we narrowed that data to those with wildfire exposure during the critical period of development, which is measured about like weeks 3 through 8 of gestation, that data consistently showed again that higher risk for ASD. However, it should be noted that wildfire exposure during pregnancy was not found to be associated with significant VSD risk across the trimesters. And so this just brings us to our conclusion that wildfire exposures during pregnancy seems to increase the risk of developing atrial septal defects, but not ventricular septal defects in offspring. And this is quite interesting because in the clinical literature, ventricular septal defects are more common. There's a higher prevalence for them. And therefore, there's potentially some sort of component to wildfire that triggers a biological mechanism or pathway that is unique to ASDs. Of course, more targeted studies are required to really understand the teratogenic effects of these kinds of exposures during pregnancy and the physiologic or anatomic impacts of said exposures. Ultimately, acquiring more knowledge of the teratogenic effects of wildfire will be essential in informing public policy aimed at mitigating these hazardous environmental exposures. And that concludes my presentation. So if there are any questions, please feel free to ask. I know that was a lot, so please feel free to type in the chat. And if you'd like to ask a question or connect after the symposium, there's my email in this slide.
Thank you, Jared. I found your research very thought-provoking. I want to start off the conversation. I wanted to ask, with the potential long-term health application for both mothers and infants exposed to wildfires during pregnancy, how might this influence prenatal care guidelines or public health policies?
That's an excellent question. So when it comes to wildfires, I feel like we need to do more in establishing, like, how do I phrase this? We have to do more in offering like financial assistance to women, especially women of color, because women of color and their health are often neglected and overlooked here in the United States. And so research like this is very important in informing public policy aimed at supporting them, especially financially, because these women, again, are more likely to be in these or in the environment where they're exposed to wildfires and therefore are more susceptible to, cardiovascular disease or respiratory issues. And so my hope is that research like this and more targeted studies will help inform public policy aimed at achieving health equity, especially for those women of color who may come from also disadvantaged backgrounds like their lower socioeconomic class.
I completely agree with you. Thank you for that. We have another question in the chat from Yvonne. She asked, how much time after the exposures were the woman diagnosed with ASD?
That's an excellent question. I'm not sure if we can find the exact time period with the data that we used. However, we did separate it by trimester. So can you repeat that question? I'm not sure if I understood it completely.
How much time after the exposures were the women diagnosed with ASD? But Professor Boy Young Park said that it's the child that's diagnosed with ASD, correct?
Yes. Mm-hmm.
Was there still a time frame for that, Jared? Do you know?
Oh, for when
For the children when they were diagnosed? Is it when they're toddlers or, when they are a little older?
So yeah, that's usually diagnosed once they're born. I couldn't really give you like a specific day or a specific period, like time frame within the course of the study, but it's they're usually diagnosed, or if like clinically speaking, they're diagnosed after birth, because these are very rare, right? They affect about 1% of live births, and so a lot of them kind of go unnoticed much until they're adults, and when left untreated, it can often lead to like the oxygen-rich blood mixing with oxygen-poor blood, and then of course resulting in the enlargement of the heart, as well as really weakening the blood vessels in the lungs.
Okay, thank you.
We have another question from Hannah. She's asking, what kind of public policies do you think are high priority to address this issue, and what kind of policies would you like to see?
Okay, so like I mentioned in the beginning, I'd really like to see a higher emphasis on the political economy and political ecology approaches of public health when it comes to this issue, by focusing on public policy aimed at supporting women in these situations. Especially, I want to emphasize, because across the literature, it's really women of color and women of like a low socioeconomic status that are affected by these kind of exposures, because they tend to live in the environments where these exposures are more common compared to those of, a higher socioeconomic status. So that's really my hope with research studies like this. I hope that answers your question.
Thank you, Jared. Does anyone else have any other questions? Okay, thank you all for presenting your research. Your hard work and effort definitely shows, and we can't wait to see what you do in the future as a public health professional. You may now return to the main meeting for the closing remarks.